Now it's time for TIPisodes with quick tips you should know. Techniques you can implement into your workflow right here on A Tale, oh yeah, A Tale of Two Hygienists.
Welcome back, everyone, into this week's TIPisode. My name is Andrew. I'm your host, and we are talking about local anesthesia. But before we get into that, I want to set the stage. On March 7th, 2023, House Bill 3824 was filed in the state of Texas. This House bill, for one of our last remaining outlier states, would allow hygienists to finally be able to deliver local anesthesia. And it went through all of the normal committees, the public hearings, all of these things until finally the House voted on it on May 12th. And then it passed in the House with 140 yeas, 2 not voting, and 7 absentees. It next went to the Senate, where it passed 31-0 on May 24th. And it currently, as the time of writing this TIPisode, is waiting for the governor to sign it into effect. So with this and Georgia and Mississippi and whoever else is on the list that have recently passed legislation for allowing local anesthesia in their states, I thought it would be good to maybe do a TIPisode on my top tricks or tips that I use to deliver safe and effective local anesthesia. Also, I am fully aware that not all states are going to allow blocks. And from what I read, and maybe I didn't quite finish all of it, but the part in the bill that I read in Texas, it looks like infiltration only is going to be allowed. And so some of these tips and tricks might not apply to everybody. Just want to throw that out there. So my first thought is about confidence. The patients expect you to be the expert, so you need to assume that aura. You need to make sure that you're not saying things like oops or whoops or whoa, or any words that might make you sound like you made a mistake. Once you lose their trust, it is so hard to gain it back. Also, make sure that you aren't asking the doctor or the assistant where things are at in front of the patient. So when you enter the room, you should know where everything is. You can't be rifling through drawers saying things like, oh man, where did they keep the lidocaine? That doesn't instill a vote of confidence, I don't think, in the clinicians. Also, especially as you are new and fighting for this legitimacy in the office, in the eyes of the patients, in the eyes of the doctors, the assistants, whoever else, you have to check and double check everything that you're going to do before you inject. This means you're going to look at the treatment plan on the schedule just to make sure that you know where you're starting. Review the previous appointment notes and make sure that whatever was put in the appointment notes matches what the treatment plan is. And also check the x-rays. Make sure there's no decay or fractures or anything on that picture. Because I can tell you I've caught several times where the doctor said number 3, but obviously meant the other number 3, number 14. But the assistant that day just typed in number 3. They didn't do anything wrong. They did what the doctor told them to do. And if you inject on the wrong side, even if it's the doctor's fault or the assistant's fault, you're still going to take some of that blame. And especially in the eyes of the patient, they're going to think that it was your mistake. And there's no ability to backtrack and blame somebody else. You never want to blame your doctor for putting it in wrong or the assistant, especially not in front of the patients. So make sure you're checking and double checking. This can take maybe up to 30 seconds. It doesn't take a long time to do, but maybe put it in your routine of in the morning you're checking it, or maybe as you're putting your gloves on, the assistant can have the x-rays up and you can just double check everything then. Just such an important habit to learn. I think also body positioning is key, especially if you're doing multiple injections every single day. I'm a standing up kind of person. So for almost every procedure I did, whether it was local anesthesia or restorative, or sometimes scaling root planing too, depending on how involved it was going to be, I'm pretty much a stander. And I think that standing up while doing local anesthesia is super helpful. One, you're going to have a very firm base. You're very unlikely that you're going to slip off the side of a chair or maybe have the wheels start to kind of roll away as you're leaning forward. If the patient moves suddenly, like sits up or something like that, then you have multiple directions that you can get your body out of the way. You can get your head out of the way. You can go to the left, the right, to the side. You can also remove the needle safely in multiple directions, depending on how they are moving. In a similar vein, I think head positioning for the patient is really important. And I think they might teach you this in school. It's been a little bit long for me to recall if that's true or not, but you should be keeping that head parallel to the floor and maybe even have the chin a little bit elevated compared to the rest of the head. And there's lots of reasons for this. I'm not really sure why I started doing this. I feel like it was those patients, those patients that kind of bury their chin in their chest as you're trying to work with them. I think I ended up started just saying, hey, lift your chin, lift your chin, lift your chin. And then I just got really comfortable doing that. And so I kept having all my other patients do it as well. And so one big upside for that is when you are having their head in the same position every time with maybe an elevated chin, or maybe not so much elevated, but that's kind of my recommendation, is you're going to have that same exact target. That muscle memory is going to be coming into effect a lot more often. So if you're missing, you'll know easily which way you need to go to fix your mistakes. And then you can repeat that motion over and over and over again. In addition to all of that, I feel like your visualization is just that much better from that position. Just my own 2 cents. So the last tip or the last trick I think I'll leave you with is about setting expectations. One of the first things that I talk to the patient about, I come up to them and I say, "Hey, Mr. So and so, Andrew, I'm going to be doing your local anesthesia for you today. How would you like this to happen? This is completely your choice. I can get this over really quick, as fast as I can get it, and it's going to sting a little bit more as I do that, or we can go a little bit slower. Just depends on how you're feeling about this. And by going slower, we're going to lessen the sting. We're going to make it a little bit more comfortable for you." And I think that you'd be surprised by how many people just said, "Just go normal speed. Just get it done. I don't want to, draw this out any longer." But for those who do want that slow and steady, I think it's key that you give them the option. And then as you're giving them that option, you also have to recognize that they're probably a little bit pain averse. And so you want to make sure you're not minimizing what their perception of pain is. And so as you're going through the procedure, you need to talk honestly with them and you need to prepare them for what's going to happen next in the process. So one of the things that you would do along these lines is say, instead of telling them, "Hey, this is a little pinch or a bee sting," or whatever people would always say before, because bee stings also have different perception. I hate bee stings. They feel like death to me, but someone else might get stung and not think that it is anything. So instead of saying like a little pinch or things like that, my honesty to them, I said, "You're going to feel a pretty big pinch right now." And then as I'm doing it, I'm saying it's going to be right now. And then I just cover the bevel of the needle with their tissue. And that's as far as I go. Once I do that, I communicate to them, "Okay, this next part, you're going to feel quite a bit of stinging. It'll get less and less as the time goes on." And so I apply a few droplets. From that point, I say, "Okay, now you're going to feel my arm moving a little bit. I need you to hold really still. You're going to feel a little bit of stinging as we continue to do this." And then I continue to droplet, advance, droplet, advance, droplet, advance. Now, in reality, I know that they're not feeling hardly anything at all. And I feel great about that. But what I'm setting them up for is kind of, not a worst case scenario, obviously, but I'm setting them up for their expectation to be a painful situation more than they're already probably thinking in their head. And then when it doesn't deliver that pain, then they feel like, "Oh, this is great." So once I get to my depth that I want, I tell them the same thing. "Okay, a little bit more stinging again. It's gonna be a little bit more aggressive than it was just a minute ago, but it only lasts a few seconds." I finish delivering. And then as I'm about ready to withdraw, I tell them, "Now we're done. I'm going to go ahead and withdraw. However, you're going to feel a little bit of stinging as it comes out as well." Now, again, reality, probably not going to feel it, but it's going to be the 1 in 100 that actually do feel it. And they're not going to be very happy that you told them that, it's done and then it hurts more. So I found by doing it this way, and you're going to have to modify this to the way that you speak and the way that you interact with patients and things like that. But I found by doing this, 9 times out of 10, they look at me like, "Andrew, I didn't feel a thing. That was perfect. That was awesome." Or, "You said it was a big pinch. That I didn't feel any big pinch at all." And then you just kind of lean into it a little bit more. Now you guys are again establishing legitimacy with your state and with your peers. You need to be the best of the best. Not saying that everyone should always try and be the best of the best, but I think that you have more at stake here. For Texas and the ones that are able to do infiltration only, your next battle, your next fight is going to be for blocks. So the war is not over on finally that we got this local anesthesia. Well, you're not quite there yet. You still have multiple steps that we still want to achieve. They're only going to be able to achieve this by not having any adverse incidents. And so, not to put too much pressure on you all, but you need to do the very best that you can. I have several more tips and tricks that I love local anesthesia. I love it so much, but maybe I'll just put those in my back pocket for next time. Oh, one quick thing. Always aim higher for your IA. And if you don't know what that means, maybe just go learn a Gow Gates. It's not the same thing. It's two different things, but go learn a Gow Gates. You're going to have a lot more success with your mandibular anesthesia. But okay, that's really the last one. So if you have any thoughts that you want to share with me, tips and tricks that you want me to share with everybody else, make sure you send me an email, Andrew@A-Tale-of-Two-Hygienists. Congrats to everyone who works so hard in getting legislation passed in your respective states. It's going to really benefit everybody. It benefits our profession for sure, but really it benefits the patients. The patients are going to have such a better experience, and I couldn't just be more thrilled for you all. Thank you so much for listening, and enjoy your weekend.
A tale of two hygienists.